Dr. Tay, can I ask you, can I ask you to stay on the podium and ask Dr. Mina and Dr. Al-Balas to come to the podium for questions?
In the toolbox you cited balloon occluded catheter. I think, we saw that in any case this tool was used because this tool is very dangerous. When we occlude there induce necrosis of colon and for the muscle and the wall of the abdomen. Yes. So it's to avoid absolutely embolization with occlusion of the feeding artery.
We tend to use occlusion balloon for the RCC cases where we ablate the whole kidney. For renal angiomyolipoma, we tend not to use because we prefer really super selective kind of cannulation. Yeah.
Do you feel there is a role for PVA? And if so, when in angiomyolipoma?
In our center, we prefer alcohol because of the ability for it to penetrate. Because it's a liquid agent, it can go very distal. The only situation where we use PVA is to supplement alcohol. As I mentioned earlier, we tend to limit our alcohol volume to about 10 cc. So for big tumors, sometimes we will give some PVA first to slow down the washout of the alcohol, and then we give the alcohol. PVA by itself, we do not have experience, but I think there are many centers who use PVA and have produced a good result as well.
Just to comment about the hypertension, so one of the critiques to Astral was the fact that in many of these patients didn't have significant stenosis. And for CORAL, the fact that there were no pressure measurement to confirm that some of these stenoses are significant. So there's still some patients in that, in that cohort that did not really need stenting. So any thoughts on that, or have you still, considered that in your practice? That's, for you, Hassan, and Dr. Mina as well.
For example, for the CORAL study, they started with transgradient, measuring the gradient, but they dropped it later on in the study because it was not practical. And most people either use the automated calculation that most machines have, or by vision. There are trends right now. What I noticed from the study is that a significant stenosis probably you should go up to 70 rather than 50 or 60 or like most of the study. And that was from one of the drawbacks on the Astral trial, that almost 40% of the patients were between 60 and 70. So probably significant stenosis has to be 70%. I don't know if you use in your practice routinely the gradient, you can measure the gradient or not. Doppler examination with the resistive index is not very helpful. So most people, I think, in real practice, they just use just measurements, either automated or...
we've been using the pressure wire, and there's enough studies mentioning that, pressure, use that as guidance for treatment. That will decrease the number of patients you actually treat and may improve your results with that. So this would be, now it's going to be harder in the US to do this trial again, and this would be something that could be done outside the US, because now there's no reimbursement for renal stenting. It's going to be an issue down the road, I think. But probably something that can be done and do with real pressure measurements, and that could be a study that hopefully will be more meaningful than what we have now.
Sure, it's a good thought.
Last question.
Yes, please. I would like to know about the control after embolization of the angiomyolipoma. What is the routine control frequency, and use CT or MR?
Sorry, for follow-up?
Yes, for the follow-up after embolization.
We tend to use a CT because it's cheaper and easier to get the appointment. But I think more and more MR has been used. In fact, I think earlier this year, there is a publication in either Radiology or AJR on the new classification of angiomyolipoma based on the various MR signal characteristics. So I'm not sure whether that will be impacting management. But for us, we have been using CT to follow up.
And at which time from the embolization?
How long after embolization?
Yeah.
3 months.
3 months.
3 months first, and then after that will be based on symptoms.
Thank you very much all for